Hey, it's Tom. Is anybody out there?
Hi, it's Colleen. How are you?
Hey, good. How are you? Let me get my volume turned up here.
Oh yeah, you sound good.
Okay, good.
So I'm keeping people in the waiting room until you guys give me the go ahead.
Okay. I just want to sort of take a look at how that, so I can see I've got on the sidebar here, Kim Keeney is waiting to talk. Oh, that's good.
Yeah, yep. So either you could admit them or I can because we're both like, we're co-hosts. So
Okay.
you don't have to admit everybody. I could handle that.
Got it. And you don't see me right now, do you?
No, I don't.
Okay. All right. And we're just waiting for Liz and the group to join. That'll be the test of their audio.
Yes.
I want to pick one. I want to pick one.
Aha.
I want to pick one.
Hello.
Gemma, can you say hello?
Hello.
We'll be muted. Don't worry.
Anyways, we have something important to say.
I know. We just got back from swimming lessons. Okay, you can pick one. Oh, there's Liz. So we can admit her.
Okay.
I'll also make her the co-host. Perfect. So we're all hosts.
So she just needs to unmute herself. She'll perhaps figure that out in a second.
Yes.
Hi, guys.
Hello.
Hi, Liz. How are you doing?
Good. How are you guys?
Good.
Good.
We can hear you well.
Excellent. Good.
Yeah.
I'm going to keep everybody in like a waiting room until you guys give me the go ahead, and then I'll admit everybody. So we can do as much chatting as we want to now. And then
Okay.
when you say, okay, let's let everyone in, and then we'll start.
Perfect. Now I'm wondering if I should have my fellows use my laptop, which I'm on right now, or if they can take over, they can share their screen, or do they have to be a host to share? In which case they can use mine.
I would recommend that again, because the if they're using their own laptops, it's my worry is that even though you think you've muted everything, sometimes it doesn't totally mute, and then you get all the reverberations. We have to do a test one day when we have like 2 or 3 laptops in there. We know how to turn off. So, are you then going to just not have any visual representation of your group, but just share the screen?
Well, we're open to.
Are you talking to me right now, or are you talking to them? Because I can't hear you at all.
Sorry. Did I go away?
You totally went away.
Okay, hang on. Let's hang on. Let me get back to it. Yeah. Can you hear me now or no?
I can. It was weird because it sounded like you just.
I turned the laptop away from me to the side because my fellow Roddy was looking at it. I guess as long as it's in front of us, it's okay.
Were you able to get one of those extra microphones or no?
No, but it's when we tested it, it seemed okay. I mean,
it is sounding great right now. So
okay. Yeah, it was definitely turned away from me.
Put yourself on the show your video of yourself.
Sure, hang on. I have to.
And I'll add myself too. Hello.
Hello. We're all here.
Great. Great. Hello. Is there a way for you to you can't actually manage it from afar and then sit in a way where we could see you? Because that was last time we were doing it, Linda Brubaker was really trying to keep us all in the screen so we could see each other as well as the presentation. So I don't know.
Yeah, I'm not even sure how to set that up because it's like, is it like a picture in picture? That way?
It would essentially be this picture on the side and you would just share. Mm-hmm. So now share your screen with me.
Let's see.
Great. So now I see for all my entire screen, I see your presentation, and over in the right corner, I see you guys.
Okay.
But your microphone is definitely directional. So if you turn your machine away from you,
right.
So
versus this, right?
Yeah.
Mm-hmm.
So if you're not all going to be, I mean, I think that the concept is that we feel like we're there with you, even though, you know, the visual of you guys in a conference room is not that exciting. It still feels like we're together.
Right.
So whatever we can do to make that feasible is great. Do you have a remote control for your laptop?
No. We were trying to use our video screen, but it's not recognizing the audio when we tested it earlier.
Yeah. Okay. So then here's the next trick, and that's where I think I will come into play a little bit more, is that if you're sitting far enough away from your laptop, you're gonna have a hard time seeing the little chat that's happening down here on the bottom, because it doesn't really, it's not that big. So you're gonna have to sit close enough to the computer to see that.
Right. Will the rest of us be able to see it though if we're on our laptops on mute?
You want to try that? Go ahead and put them on. Try having them turn on their computers and mute and see what happens.
Okay. I don't know if they'll be able to log in though, if they're blocked right now, or if Colleen can unblock specific people.
Oh yeah, I can admit them when they come on.
Do you have the Zoom link, or I can send it to you? Okay. I still don't know though. Yeah, that might work.
I don't know.
We're
at least we could see the sign.
Yeah. Okay. Well, let me escape out of that and go back to the invitation. Just let me send it to you guys. Give me just a sec. Let me just email them the link. All right, I'm emailing them the Zoom link, and I'm getting a dongle to see if I can hook up to our main screen. Can you still hear me okay?
I can still hear you well.
Okay, good. Oops, where'd that go? That one.
Tom, I like your I care little badge holder.
Oh.
I like that.
Yeah. I forget what it's supposed to say. Stand for something, and like I'm supposed to do all the time, and I can't even remember what the hell it stands for.
Did one of the fellows just join?
Yeah.
What are their names, Elizabeth?
Radhika Patnam.
Okay, I'll admit her so she can test it.
Perfect.
So she'll want to mute her computer though. So she's joined. And then is the other one Catherine?
Yep, Catherine.
Okay, I'll admit her as well.
Awesome.
All right, so all of us are in there.
Great. So theoretically, then, Radhika, why don't you talk for a second and see if you can use.
Okay, this works.
And maybe have them turn their videos on.
So the cool thing, I was just able to log on here. Oh, let me unshare. Sorry. I don't know. Is my video still on?
Now I'm looking at I'm looking at your Outlook.
Okay. Oh, wait, stop share. Let me do that. Sorry. There we go. So I've got it up here now, like on our main screen, at least for visualization.
Great.
So that helps, but it's still, I think, it's just going to show the picture of the presenter. Which maybe isn't the end of the world. I don't know. That's the only thing that'll be.
Yeah, I just see Tom 2 places.
Yeah.
If I share again.
Then you just need to put your slideshow on. Yeah. So that I mean, I can see that now. I'm looking at your slideshow presentation rather than the actual. Like I see your presentation view rather than you might need to go to the other screen or something.
Yeah, or I wonder. display settings. What about now?
Yep, that works.
Okay. So, I mean, this works at least so we can see the big screen.
Are you seeing the chat room too?
No, just the PowerPoint. But the rest of us can be on other laptops seeing the chat.
Yeah.
Can you see the chat, Katie? Or Roddy?
All right, so I just heard, I think I'm hearing reverberation, but maybe I'm, are you hearing anything, Colleen?
You see how to mute it, Katie?
No, I'm not hearing any echo. It sounds okay.
Okay.
Can you tell she's not?
I'm just hearing echo myself a little bit.
Right.
But maybe it's just me.
We're checking it.
Yeah, Catherine may need to be muted. If you could tell her to mute her computer.
Working on it.
Okay, fabulous.
Mm-hmm. I wonder if, let me share a minute to stop video and then share again. Then I wonder, do you just see the PowerPoint now?
We just see the PowerPoint now.
Would that be reasonable to start with, and then we can go back to us for the discussion, or what do you think?
Yeah, can you start with when you introduce yourselves, saying, just like putting it yourselves, and then go back and maybe something like that, just sort of wave and say, hey, here we are.
Right, yeah, we can start it that way. And then
it's just the three of you guys is
and one of my colleagues, Marcy Willis Gray.
Okay, yeah, great. Hello.
Just gonna look a little awkward. I know, pulling it forward, but we'll figure it out.
All right, and just remember that your microphone is really directional, so if anybody else in that room is speaking, we're gonna have a hard time hearing.
Right. Yeah, I mean, I wonder if we all want to sit together on one side.
Yeah, I would say definitely do that. Yeah.
We can see, yeah.
Then we can be around the curve, maybe.
Colleen, when we chat, they can see the chat, but they can't hear and see the video right now. Everybody?
Yeah, I can see the chat.
Can the people who are like on the waiting room see the chat?
Oh, no, not yet.
Okay.
They will once I let them in. So you guys just let me know when you want to let everybody in from the waiting room. We have 8 people waiting right now.
I'm just thinking this is kind of far away where we are versus. Yeah, versus all just being. Yeah. I don't know. Yeah, I have to keep doing it.
Oh, yeah, wait.
Okay. Yeah, it's just not going to reach. It's not going to reach all the way, but I wonder, the other thing I could do, like, Roddy, can you take the screen? Can you do share? So, I could show and go back to this. The whole, like, I see everything, like this whole view.
It's just down here.
Oh, yeah, so share. If you do share, you can take it. And then you put, that's what you're going to share.
Okay.
So what we could do is put it on video while we're saying hi, and then let Roddy take over the screen and I mute to present.
Okay.
I think that would work. How's the audio right now?
That's great right now. As long as you're talking right at your screen, it's awesome.
Okay.
It's from the side.
No.
Just because, like, when we have a conversation about things, it'll be nicer to be able to hear you guys in the room as opposed to.
Right.
So I may, if things get a little funny, I may chat at you down in the corner saying, "Hey, fix your audio," and I might just do it privately to you.
Yeah.
Because at the bottom you can see that the chat area you can choose both everyone, and you can choose to talk to one person at a time. Just make sure you kind of pay attention to that if you choose to talk to everybody or to one person at a time.
Hang on, I'm trying to put it back further to see if that is better.
That looks great.
Can you hear me right now? Well,
Why are you on mute?
no, I'm saying if I can we can just do it through that one. We won't be moving around. Can you hear me right now?
Yeah. That's awesome. You guys sit cheek by jowl.
Yes.
And you can hear me right now?
I can totally hear you now.
Okay. So
Are you going to do
that?
this or that?
That way I can use the notes off here.
So you're going to reach forward to advance every slide, though? That's the only problem.
You may have to do the advancing.
Yeah.
Okay. Then I'll just move it.
Yeah, it might be better for you to take.
Either way, you'll be on the small screen when you're actually doing the presentation. It won't be as but we'd like to see you. It's kind of cool.
Exactly.
You guys ready?
I guess so.
Okay. Colleen, you want to let everybody in?
I'm going to let everyone in.
Okay. Great. I think we have just let all the rest of the folks in. We've been sitting here doing some testing. Hi, everybody. I'm Tom Gregory. I'm one of the associate editors of the FPMRS journal, and we welcome you to our third edition of a kind of cross-country, actually cross-world, potentially, journal club. And I'll turn it over to the folks at UNC in a second, but and let them say hello. And I see Linda now on the screen saying hello too.
Hello.
I can see you talking, but I can't hear you talking.
All right, this should be better now.
Yeah.
I just wanted to thank our colleagues at UNC for hosting this journal club and saying hello to everybody who's joined us, and pass the word, nudge the folks next to you if they're still not on. So this is going to be a good time. Thanks, everyone.
Thanks, Linda. As we're sort of transitioning here, I wanted to take a moment and kind of go over a couple of some ground rules. If you guys at UNC could go ahead and share your screen for me, then we can kind of put Linda back over to the side for a second. Great. Yeah, perfect. And so we're going to talk about a couple of articles, and I just wanted to, and I can see that everybody's kind of playing by the rules already. Essentially, you're listening into, UNC's journal club, and so it's essentially kind of like we're eavesdropping a little bit. Eavesdropping in a way that we can kind of communicate on the side as well as to each other. We went ahead, and after we posted the articles, I think yesterday, we just sent an email with some discussion points that we may get to. We may talk about other things, but I wanted to at least have something to work from. As a default, your microphones should be muted. If you'd like to say something, go ahead and unmute yourself, or even I think you can there's a place where you can kind of raise your hand, I think. But what we've been noticing is that using the chat feature, and let me go ahead and just say something here, we can communicate with each other, and actually while other people are talking, we can have a conversation on the side, generate some discussion points, maybe even ask each other questions, or potentially ask questions of the folks at UNC who may kind of pull in some of their comments from that. So that's a really great way that we've seen to kind of communicate with each other and kind of talk on the side. I think I've already talked about being muted. Go ahead and go to the next slide. Yeah, so, go back one, sorry. It's really, we really do want sort of to be an engagement, so that's where the chat feature kind of comes into play. We don't want this to be just two or three people just doing all the talking. So again, this chat room makes that happen. And then finally, before we get going, go ahead to the next slide. I think we've already decided now on the next journal club, which will be Thursday, August 29th at 2 p.m. That worked really well with the folks, Megan Schimpf and her group at Michigan. They'll all be together just like the folks at UNC and we at OHSU and the folks at Hawaii were, so that there'll be already a kind of a communication happening. So we'll redo this in a couple of months with a couple of new articles from our journal and potentially from another one. So with that, I think we can go ahead and let the folks at UNC say hello to us, introduce themselves, and then get going on a couple of these articles. I'm going to unvideo myself. I'm going to, in a moment, mute myself, but I'll try to keep things going if necessary. Thanks a lot, everybody.
Yeah, well, welcome. Thank you, everybody, for joining. I'm sure people will continue to join. I wanted to introduce our group here. We've got to my side here, Radhika Putnam, our second-year fellow. I'm Liz Geller, and then we've got Katie Husk, our third-year fellow, and Marcy Willis-Gray, one of our other faculty. Our other faculty send their regrets they weren't able to attend: Alexis Dieter, Anna Marie Connolly, and Jennifer Wu. So I think we're going to get started. And as Tom said, feel free to send in chats or raise your hand, so to speak, and we'll be able to answer questions. We've got some great discussion points set up for each talk between them. So I think we'll get started. So we're going to switch over. I think you can take it if you do share. So let me stop sharing. And then Dr. Putnam's going to take over.
All right. Hi, my name is Radhika Putnam, and I'm going to be discussing pelvic organ prolapse repair using Uphold Vaginal Support System, the 5-year follow-up.
Can you guys hear us okay too? Okay.
We can hear you really well.
Great. So the background for this study is that in October of 2008, there was a public health notification that informed patients and clinicians on how to mitigate risks with regards to vaginal prolapse mesh. At the time, in the intervening years since that time, there's been 2,874 medical device reports, including injury, death, and malfunctions. Therefore, the FDA did an update in July of 2011. At that point, they stated that, different from 2008, there were serious adverse events were not rare, and that transvaginal mesh in POP repair does not conclusively improve clinical outcomes over traditional non-mesh repair. The FDA then had withdrawal of vaginal mesh in April of 2019. At that point, the FDA ordered manufacturers of vaginal mesh, including Boston Scientific and Coloplast, to stop production of mesh. They said this is for all mesh intended for transvaginal repair of anterior compartment prolapse. Women who had received vaginal mesh should continue with annual care, and there was no need for additional action, including mesh removal, unless the patients were having issues. The specific symptoms that they had listed at that point included persistent vaginal bleeding or discharge, pelvic or groin pain, or pain with sex. They felt that the manufacturers had not demonstrated a reasonable assurance of safety and effectiveness. This study is looking at this lack of information on long-term outcomes for vaginal mesh. There's a recent Cochrane review that showed that mesh is not superior to native tissue repair with regard to recurrence rates. However, most of the studies were small, with heterogeneous mesh products and a variable follow-up time of 1 to 3 years. The objectives here were to assess a 5-year outcome of the Uphold Vaginal Support System, which is a specific vaginal mesh system for pelvic organ prolapse. They were looking at anatomic support, pelvic floor symptoms, sexual function, and pain. And of note, the sexual function and pain are 2 of the major symptoms that followed from the FDA announcements. So this was a prospective multi-center cohort study in 24 GYN centers in Sweden, Finland, Denmark, and Norway. It was a follow-up of a previously reported 1-year outcome, and the Uphold surgery was done with or without anterior colporrhea. There were no other concomitant surgeries performed, and patients were collected from February of 2012 to June of 2012. The study design, in terms of inclusion criteria, it was apical prolapse with a C greater than -1, and they could have anterior prolapse. Exclusion criteria was other clinically relevant prolapse. cervical elongation, posterior wall prolapse, or stress urinary.
Just as a reminder, if you're logging in, keep in mind to mute your microphone. Thank you.
Other inclusions included current pelvic cancer, insulin-dependent diabetes, connective tissue disease, rheumatic disease, or steroid treatment. So women were contacted 5 years post-operatively for a follow-up visit. They had a POPQ collected. There was also POPQs collected before surgery and at all subsequent visits in that time period. And a stage less than 2 was considered optimal objective outcome. They also had a vaginal inflammatory scale for mesh erosion, which was graded from 0 to 4 in several areas, including granuloma, erosion, necrosis, infection, and rejection. The PFDI-20 was collected with an optimal score if the total score was greater than the preoperative score by 23 points, which they defined as the minimal important clinical change. They also collected the PISQ-12, and they collected pelvic pain information using a visual analog scale of 0 to 10. The analysis was continuous variables assessed with the Mann-Whitney U and categorical with chi-square testing. They compared between 1 and 5 year outcomes with the Wilcoxon matched pair signed rank test. And possible risk factors for unsuccessful outcomes were evaluated with a multivariate logistic regression. With regards to sampling, there was no power calculation and patients were actually chosen per surgeon discretion. For results, 207 women underwent surgery and 164, or 81%, completed the 5 year follow-up. 138 had POPQ results at that time, and 153 had completed questionnaire data. 110 had isolated uphold procedure. 48 had an uphold procedure plus an anterior repair, and 71 had a history of a previous anterior repair. With regards to anatomic outcomes, the optimal apical outcome occurred in 94% of the population, and when excluding women with reoperation for prolapse, the success rate was 83%. Looking at the anatomic outcomes, success was more common among women with prior or concurrent anterior repair, and 22.4% had anterior prolapse at 5 years postoperatively, and 25.4% had posterior prolapse. Looking at the subjective outcomes, the optimal PFDI-20 scores were optimal in 78.8% of women. All domains of the PFDI-20 improved from baseline to 5 years postoperatively with no significant difference from years 1 to 5. 87% reported no bulge symptoms or no bother from bulge symptoms, but those with bother from bulge symptoms did increase from 9.5 to 13.2%. Bother from urge incontinence symptoms decreased from years 1 to 5 from 41% to 35%, while bother from stress incontinence symptoms increased from years 1 to 5, going from 38 to 42%. With regards to sexual function, the number of sexually active women decreased from baseline of 88 to 1 year post-op at 69 to 5 years with an N of 55. The rate of any dyspareunia decreased from 59.2% at baseline to 42.9% at 1 year to 36.4% at 5 years postoperatively. While sexual activity decreased by 5 years post-op, sexual satisfaction increased among those who were sexually active in all domains compared to baseline and 1 year postoperatively. For dyspareunia, 64% reported none, 15% reported seldom, 16% reported sometimes, 2% reported usually, and 4% reported always. The rate of pelvic pain, based on those visual analog scores, decreased significantly from baseline to 5 years postoperatively, with no difference between the 1 and 5 years post-op. These are the secondary results. With regards to reasons for follow-up visits, 7% was for pelvic organ prolapse, 7% was for urinary incontinence, 3% was for pain, and then 1% for both mesh problems and recurrent UTI. With regards to mesh complications, there are 2 mesh granulations and 2 mesh erosions. One was grade 1, one was grade 2, and the erosion rate was 1.4%, but that did not include granulomas. Additional surgery, with regards to the patients who did have that additional surgery, 40% of those surgeries were mesh slings, 15% were posterior colporrhaphies, 8% were mesh removal, 5% were sacrocolpopexies, hysterectomies, or a new mesh implant, and 3% were either anterior repairs or sacrospinous ligament fixations. So the authors concluded that both apical and subjective success were maintained at 5 years. Apical success was associated with previous anterior colporrhaphy, and little change in the PFDI or PISQ between 1 and 5 years. There was a significant improvement compared to baseline. Nearly 20% of women underwent additional surgery between the 1 and 5 year visits. Most common, this occurred in the patients who had the isolated uphold procedure, and 39% of the recurrent surgeries were mid-urethral slings, and the authors concluded that women may benefit from a concomitant sling. Overall pain decreased significantly between 1 and 5 years. 3 women had persistent severe pain at 5 years postoperatively. Women with preoperative pain syndromes may be at particular risk for pain complications, and pain after vaginal mesh procedures may be related to either the surgical technique or the mesh itself. They noted in particular that injury with dissection, suturing of mesh to inappropriate pelvic structures, or tension of mesh could be a cause. They also stated that good knowledge of pelvic floor anatomy, appropriate hands-on training, careful patient selection, and maintaining high surgical volume for mesh implant are all important for optimal results. With regards to study strengths, the positives are that there's a long-term follow-up of 82% of the original population. They used validated instruments for outcome measures. In the original study, there was standardization of the surgical methods and postoperative follow-up, and they had a stringent definition of apical recurrence, which was greater than or equal to stage 2. Limitations was that there is a lack of a control group and that there are several biases, including that the operating surgeon evaluated patients postoperatively, and inclusion criteria was based on surgeon selection. There was also minimal assessment of pelvic pain with only a visual analog scale, and there was no discussion of its relationship to mesh. So we can pause for a second here and see if anyone has any points that they'd like to bring up at this time.
And we have some discussion slides to help guide discussion, but if there are questions, I don't know, Tom, if you want to moderate those, we can address any of those as they go along.
Sure, I think that you have done, I can see Linda already putting this in here. You guys did a great job of presenting that, and I've already started beginning the process of trying to unpack this a little bit. I think I would go ahead and let you guys talk about the discussion points, but one of the things that I want to talk about is the mesh erosion rates, or the mesh complication rates, and then the definition of success here, and how they've defined it and what their findings are, and then the sort of secondary outcomes that you've noticed with the anterior wall descent versus the optimal apical descent. So go ahead and do what you've got there, but I'm happy to sort of see what other people have in their chats if they want to bring up some other questions.
Okay. So the first thing we kind of wanted to discuss was the reoperation rate. So 20% of women underwent additional surgery between the 1 and 5 years. And one of the things that's interesting about the population that was looked at here was that it occurred in countries that have universal health care. So what do we think the effect of universal health care has on follow-up rates, not only for the patients coming in to have surgery, but their willingness to have a reoperation in that time period versus the US?
So, yeah, so do you think that the point is here that in the Scandinavian countries that there is a significantly higher rate of the follow-up rates than would be here in the, let's say, the United States?
Yeah, I mean, it's possible. I think that was the question that we weren't sure how it might affect it, if people are more likely to come back in for assessment or have a reoperation versus here having obviously the healthcare costs, if they would delay it unless it was, you know, severely bothersome.
I think it's partially why they had such a high rate of follow-up at the 5 years, because patients are coming back in and being seen more often. That could also be a big factor.
do you think it's also part of the fact that they're in a prospective study and therefore they are already kind of bound to be coming in?
Well, the original study, I think, was looking at a year. So I think that's obviously a factor in there, but it's also a lot of times I feel like our patients are harder to get a hold of. And that often is associated with the fact that, you know, they go to different hospital systems or have complications and it's harder to find.
I'm seeing one of the comments here from Dr. Osmondson that, you know, that maybe there is concern about the people who didn't follow up, if they had problems associated with like pain or erosion. I know that you're talking about mid-urethral slings and other surgeries, but I wonder if we've missed some people who didn't follow up, and that's one of the questions.
I don't see that they address that in their paper.
They don't, nor do they even address the difference in any of the demographics between those who were followed up and those who weren't.
So that certainly could be a factor.
Yes.
Should we move on to the?
Yeah.
Keep on going. This is interesting. I know it's real hard to kind of, you know, we're waiting for people to kind of talk in. You guys just keep on having the conversation there.
Okay. The next thing we brought up was that level 1 and level 2 support was crucial for an optimal result. And the question that they are bringing up here that they don't entirely answer but are considering is, should all women undergo a concurrent anterior repair when having the uphold done? And which women should receive a vaginal versus laparoscopic apical support surgery? So when we were discussing this earlier, we thought that one of the issues with understanding whether or not all women should undergo a concurrent anterior repair is because they specifically only had women who had anterior prolapse included in this study, and specifically didn't include patients who had a posterior prolapse. So I think that adds an aspect of wondering, is it necessary to do an anterior repair, or did they self-select for those who are going to need that anterior repair, thus pushing us to see that the success rates were higher in those who had the concomitant surgery?
Yeah, and this is where I think I wanted to kind of point this out and and sort of see if other people notice this. And I think it's pretty straightforward, but you know, they do talk about their high level of what they're describing as optimal outcome, but their definition really is about the apex only. And so it was clearly defined that the apex was their, that they were going to do either an apical repair or apical and anterior repair, but that's it. But then they had a inclusion criteria that was just about the apex. But as we know, a lot of times the apex can still stay way inside the hymen, and yet the anterior vaginal wall can come out. And so, can you go back or at least reflect with us what the rates of anterior vaginal wall prolapse was after surgery at 5 years compared to the apical? You know, that number is significantly different, between 98% versus like 70-something%, right?
Yeah, it's a big difference. When you look at even comparing what their idea of success is in the two groups, the anterior wall and the isolated uphold, there was 28% who were still at stage 2. And then with the uphold and the anterior colporrhaphy, it was still 34% who had a anterior wall stage of 2. So there's still a significant amount who go beyond that expectation.
Yeah, absolutely. And then go on to I think your next point is really more of conjecture, isn't it? Because it kind of maybe leads into the discussion about, for our next paper that we'll discuss, which is about alternative choices between vaginal surgery and non-vaginal surgery, mesh versus non-mesh. Is that right?
Yes, yes. And it was kind of a lead into that, in that this is kind of the question I think everyone is wondering right now, and will be perfect for Dr. Husk's
Great.
journal.
Why don't we move on to some of the other discussion points, and so that we can kind of leave that as like a little tease.
The discussion, the second discussion question is about mesh and pain, which is always a major issue that everyone's really interested in. There are high dyspareunia rates in the small number of sexually active women. And one of the things they bring up themselves is they don't know why so few women were sexually active at the 5-year period. They didn't ask that as part of their questions. And then there's no real explanation as to why the dyspareunia is so high. They didn't do any further follow-up questions. So those are two things that we really have to kind of wonder about in this population that's not really well addressed.
Is it your perspective that that's significantly different than other studies in terms of both decreasing sexual activity over a 5-year period as well as generalized sexual disorders, including dyspareunia?
I think that it's not uncommon to see the sexual activity rates go down, obviously just with age as well. But I think their dyspareunia rates may have also appeared somewhat high because it was any dyspareunia, which we broke down to show what percentages were mild, moderate, severe, and the majority were mild to moderate, and with only 3% being severe or often having pain with intercourse. So I think that may inflate it a little bit, that even though there was a high rate, the severity was not very high.
Yeah, and Dr. Manalia is kind of making a good point here too, which is that, you know, making sure that we are evaluating sexual pain, just general pelvic pain is important. And I know that I've been involved in a couple of articles that sort of explore that. Is myalgia, is sexual dysfunction, is sexual pain related to prolapse? Does fixing the prolapse adjust that? Does prolapse feel worse because of pelvic pain? And what's the chicken and what's the egg? So these are really difficult things to certainly understand, but making sure that we explore it with our patients so that we can do a good job of counseling is key, I think.
Right. I think Dr. Osmundson has a good point about being afraid of putting mesh in someone with baseline pain. I think that's one of the few things we have proven fairly definitively, that baseline chronic pain, has a high risk for exacerbation of pain with mesh implant. So what is our option for that?
Yeah.
I will say I was impressed they at least included a VAS, because a lot of studies only use dyspareunia as a proxy for pelvic pain and don't necessarily have a direct measurement. So while it's a simple basic measurement, I think it's a good start.
Cool.
All right, moving on to the next discussion point. With regards to a study redesign, obviously that there wasn't a baseline group to be comparing it to. And there's actually a trial out right now, the SUPER trial, which is a study of uterine prolapse procedures. It's the study of uterine prolapse procedures randomized trial. This is an effectiveness and safety of 2 transvaginal apical suspension strategies for women with symptomatic uterovaginal prolapse beyond the introitus. Excuse me. So it's the 3-year results of a hysterectomy uterosacral ligament suspension surgery versus a hysteropexy uphold. They have recruited 180 participants, and that recruitment is complete. So it was before the FDA warnings came out. And they're going to do a primary outcome of a composite of success defined as no prolapse symptoms, no objective prolapse beyond the hymen, no retreatment of prolapse. And then they're going to look at a minimum of 36 months post-surgery follow-up using survival analysis. And then their secondary outcomes were measured at baseline and every 6 months post-surgery, which are validated condition-specific and general quality of life assessments, and then a global impression of improvement, body image, and sexual function measures. So I think that study in particular is going to be really helpful to help us understand exactly what the uphold is doing versus another very common vaginal apical support surgery, and give us a lot of the information I think we're looking for from this study. The other thing we wanted to mention was the ASPIRE trial, which is an RCT of sacrocolpopexy versus sacrospinous ligament fixation versus uphold. The enrollment changed due to the new laws, and so the remaining numbers will be just sacrocolpopexy versus sacrospinous ligament fixation. But from what I understand, they've had a large number of people already enrolled, so we will get some good data from that as well with regards to the uphold product.
So I really think that'll be key moving forward with what the future holds for any type of vaginal mesh, to get, these data to show us maybe what the benefits and outcomes are for each type of surgery. So I think we're lucky they've got as much enrollment as they have.
Yeah, and I think that your next discussion point kind of brings it to the kind of a conclusion, but that certainly is, I think, one of the biggest questions that our entire society and all of our colleagues have is, what is the future of not only these two products, marketed by the companies, but the ongoing use of transvaginal mesh, and how do we, if the FDA is sort of pulling things back, and how do we then use these data what do we do with this? And so I know a lot of people, I know that Dr. Cundiff, certainly with his one of their last presidential perspectives, sort of talked through that with us, but clearly we need to continue to kind of figure out how to do that.
Definitely. And I think that leads into the next slide as well, which is just what is the future of uphold or vaginal mesh for prolapse at this point. And I think, again, these studies will help us figure that out.
And I think this study in particular is a good starting point, but those randomized controlled trials are really going to give us better answers than something like this can.
All right, and I think that's a good segue into the next presentation. Did you want to share it on your laptop? I don't know if you have it to. Or do you want to sit there? All right, I'm going to switch places.
I'm going to do some musical chairs.
Roddy, can you take the chat box off of that one? Just switching our presentation. No, that's okay.
Yeah, I have it.
We do. Yeah, we can exit out. Let me do this. I'll do that. Perfect. All right. So Dr. Husk is now going to talk to us about prolapse recurrence following sacrocolpopexy versus uterosacral ligament suspension, a comparison stratified by pelvic organ prolapse quantification stage.
Okay, so it is estimated that there is a 12.6% lifetime risk of surgery for prolapse for women in the United States. Counseling about surgical options focuses on the trade-off between durability of repair and surgical risk. Proposed pros of use of mesh include improved anatomic success and reduced reoperation for prolapse recurrence. Cons are considered mesh increased complication rates and total reoperation rates. Advanced stage prolapse is a known risk factor for prolapse recurrence. However, systematic review data combines women with stage 2 through 4 prolapse, and it is unknown how procedures compare for women with different prolapse stages. Therefore, the objective of this study was to compare prolapse recurrence rates following sacrocolpopexy and uterosacral ligament suspension after stratifying by preoperative POP-Q stage. This was a retrospective review of a surgical database of women who underwent sacrocolpopexy or uterosacral ligament suspension through the division of FPMRS at the University of Pittsburgh Medical Center. Sacrocolpopexy data was available from January 2009 through August 2015, and uterosacral ligament suspension data was available from January 2011 through August 2015. They excluded women who were missing preoperative and or postoperative POP-Q data. The surgical procedures for the sacrocolpopexy were all minimally invasive, either laparoscopic or robotic. For uterosacral ligament suspension, these were performed vaginally, laparoscopically, or robotically. If the uterosacral ligament suspension was done post-hysterectomy, meaning a prior hysterectomy in a separate procedure, then only laparoscopic or robotic procedures were completed. Attendings operated with an FPMRS fellow and an OBGYN resident, either a second or third year. Data was abstracted from the surgical database on the following information: demographic information, prior hysterectomy or prolapse repair, POP-Q preoperatively and postoperatively, the date of the most recent follow-up visit, and evidence of treatment for recurrent prolapse. They defined recurrence as any retreatment of prolapse or any POP-Q point past the hymen. For statistical analysis, variables were compared using students' t-test, chi-squared, or Fisher-Exact as appropriate. The rates of prolapse recurrence were compared with chi-squared. The logistic regression analysis was performed by stage, and they considered a priori certain confounders, including age, BMI, smoking status, diabetes, and prior prolapse repair. Some groups, specifically stage 2 and stage 4 prolapse, were too small for logistic regression to be completed, and they performed sensitivity analyses. Overall, there were 1,007 women with sacrocolpopexy or uterosacral ligament suspension. In total, 756 had complete preoperative and postoperative POPQ data. Overall, more women underwent sacrocolpopexy, or N equals 633 or 83.7%, than uterosacral ligament suspension, N equals 123 or 16.3%. The median time from surgery to follow-up was longer for sacrocolpopexy with a median of 47 weeks versus uterosacral ligament suspension with a median of 28 weeks. This median time from surgery to follow-up was significantly different between the sacrocolpopexy versus uterosacral ligament suspension group with a P of 0.008. And they discussed this in a little bit more detail, stating that their practice for native tissue repair is to have many women transition their care back to their local provider after surgery, but that they request specifically that their sacrocolpopexy patients follow up annually for mesh surveillance. With respect to baseline patient characteristics, there were no differences between the groups with respect to age, race, parity, BMI, or smoking status. Individuals in the sacrocolpopexy group were less likely to have diabetes and more likely to have undergone a prior hysterectomy and or prolapse repair. The majority in both groups were stage 3 prolapse, and there was a trend towards more severe prolapse in the sacrocolpopexy group with a P of 0.069, but not statistically significant. For their primary outcome, for women with stage 3 prolapse, sacrocolpopexy was less likely to result in prolapse recurrence than uterosacral ligament suspension. There were no differences in recurrence rates for stage 2 or 4 prolapse, although the sample sizes were small and they had limited ability, therefore, to draw conclusions. Due to the low recurrence rates in stage 2, they performed a sensitivity analysis instead of regression, and when excluding those with a prior prolapse repair, there was still no difference in recurrence rates. For their logistic regression model for recurrence, only stage 3 prolapse had the regression analysis performed. Overall, uterosacral ligament suspension remained significantly more likely to have recurrence than sacrocolpopexy, and again, that was controlling for age, BMI, smoking status, diabetes, and prior prolapse repair with an adjusted odds ratio of 4.3. They also looked specifically at the compartments of prolapse. So the above table shows preoperative and postoperative POPQ points comparing procedures performed, the sacrocolpopexy versus uterosacral ligament suspension by preoperative stage of their POPQ. In stage 2 prolapse, there was a small but significant difference in total vaginal length and C point, with sacrocolpopexy having a longer total vaginal length and more supported apex compared to uterosacral ligament suspension. For the stage 3 prolapse group, there were similar findings, as well as a more supported anterior wall in the sacrocolpopexy compared with uterosacral ligament suspension. In the stage 4 prolapse group, only the total vaginal length was significantly different. So the authors made the following conclusions. Women with stage 3 prolapse were less likely to have prolapse recurrence with sacrocolpopexy versus uterosacral ligament suspension. Women with stage 2 prolapse had similar rates of recurrence regardless of the procedure performed. They recommended considering a native tissue repair for stage 2 prolapse and mesh augmentation for stage 3 prolapse based on their results. And overall, they advocate for a revised surgical counseling tailored to an individual woman's prolapse stage. For study strengths, they had large overall numbers with an N of 756, and they used both a patient-centered or subjective outcome retreatment, as well as an objective outcome or POPQ point beyond the hymen. There are a few potential study limitations. First, this was a retrospective study, and surgeon preference for surgical procedure could introduce bias. As well, this was performed using a surgical database, which limits the available data. For example, we have no information about the rate of concomitant surgeries, such as hysterectomy or colporrhaphy, as well as their effects on recurrence rates. With respect to generalizability, they had primarily Caucasian participants, and they represent a tertiary care and referral center. There was also no a priori or post hoc power calculation, and so given their description, they may be underpowered for stage 2 and 4 analyses. There was a relatively short-term follow-up for both groups of patients, as well as a difference in follow-up duration for sacrocolpopexy versus uterosacral ligament suspension, and we are lacking some information about time to recurrence. So I will pause here for any questions or comments, and then we can follow by moving on to our discussion points. Oh, okay.
See, there was some chatting going on while the presentation was going on. I don't know, Tom, if you wanted to share some of that.
Well, I think that part of the discussion that we were having is just one of the things I was saying is, does this feel like what you expect from your own personal experience? And then the second points that Linda were making is, you know, how do you weigh, or how do you let your patients weigh the difference between problems with mesh and problems with recurrence, and how do these conversations go? So, yeah, those are some of the main things that were going on there.
Yeah, I think it is really helpful to stratify it by stage, because I think that's something we all do, but to have data actually making that comparison is helpful, despite the fact they may have been underpowered for the extremes, like less prolapse and advanced prolapse. But I think for stage 3, if nothing else, I think is very helpful.
Do you think then, and this is kind of maybe one of your discussion points, is do you think that the bias of the surgeons at the site from which this comes, a priori, their decision about who is going to get actually colpopexy versus uterosacral ligament suspension, do you think that has plays a role here in how the data are being analyzed?
Well, this may feed into this first discussion point very nicely.
Yeah. And so I guess one of the things that we had brought up was how might the practices at the study site have impacted differences between the cohorts, as well as subsequent analysis. And some of the points that we had considered was that they excluded patients if they had no preoperative and or postoperative POP-Q. From their description, there are approximately 250 women that were excluded because of incomplete data with respect to POP-Q. They did not specifically discuss which cohort these patients were part of, but in discussion of their practices, it seems more likely that this represented the uterosacral ligament suspension group disproportionately. They also talk about their follow-up practices, which could potentially have impacted things as well, as they recommended that their native tissue repair patients more typically follow up with a local provider versus their sacrocolpopexy patients were advised to return yearly for mesh surveillance. This does kind of bring up the question as well, then whether their native tissue repair patients would be more likely, if they had recurrence, to then return to their surgeon and sort of disproportionately be represented in that group. And then, as you brought up, they were more frequently performing sacrocolpopexy overall than uterosacral ligament suspension, and how that selection factors into analysis as well.
Yeah, really important. I think that maybe it doesn't necessarily change some of the findings drastically, but I think that's really key to think about. The longer follow-up, the more people following up the bias ahead of time. Yeah, absolutely.
I think Steve has raised his hand politely with a question or something.
Trying to be as polite as possible. Can everyone hear me okay?
Yes.
Yeah.
Okay. I mean, like every study, it's a great study and it's a terrible study, right? You know, there's 7 surgeons and we don't know, are all 7 doing a little bit of uterosacral, or is it 1 or 2 people? And I found it's a great study overall, but the limitations have to be taken seriously. So, you know, the failure rate was quite high in the uterosacral ligament suspension group. And if they had followed them up more, you know, long term, we would only anticipate they would have captured higher failures. And the sacrocolpopexy group was followed regularly, so we don't anticipate more failures to occur. But just to kind of compare, if you look at the Milani study that published last May, June in our journal, 2018, you know, they looked at 583 patients and their failure rate was more, their failure definition was more stringent, and it was 13.7%, and then the reoperation rate was only 1%. So the technique matters, and it's very important. And the problem with the study is the technique's not described, and we don't really know who's doing it, and we don't know anything about concomitant repairs, which is a big problem. So what I find most useful, as you folks already said, we can't really make conclusions about stage 2 and 4 prolapse, but let's say you're looking at a stage 3 prolapse and all things considered, the patient's okay with mesh and doesn't want recurrence, and you don't have a contraindication to go in her abdomen. I think you could use this data to say, okay, I think we should do a sacrocolpopexy as opposed to a uterosacral ligament suspension. But then it goes back to the individual person and you as the surgeon knowing your numbers inherently.
We've got about 15 minutes left in the total time. I want to make sure we get to other discussion points and give everybody a time to sort of chime in. So yeah, perfect.
Please raise your hands with questions or chat as we go on.
So I guess that's sort of a good lead in, I guess, for our second discussion point was how do we interpret the POPQ findings for sacrocolpopexy versus uterosacral ligament suspension? So for some of them that were statistically significant, are these clinically significant? Postoperatively, there was a small but significant difference in the TBL and C point favoring sacrocolpopexy in stage 2, and a similar pattern seen in stage 3 and 4. The stage 3 patients additionally had mildly improved anterior support. As we've discussed previously, it's unclear which compartments had prolapse recurrence, so does this impact our interpretation of these results? And just as an aside, it's a little unclear when these POPQ measurements were performed, and so it's not clear whether those were done at the most recent follow-up visit or when relative to the postoperative follow-up.
So I think that speaks to what Steve was saying with the heterogeneity of it, that, we think there's other elements that are going to go into the decision making, but at least it gives us some data to quote, at least in terms of success rates, recurrence rates, level of prolapse.
And then finally, as we had discussed before, should these findings change our counseling practices? So for example, should we consider stage 3 and 4 prolapse different from stage 2, even if they've not had a prior hysterectomy and or prolapse repair? And are the numbers in this study for stage 2 prolapse adequate to change our practice patterns? How does this impact our ability to counsel stage 3 and 4 patients versus stage 2? And how do we weigh the risks and benefits of mesh? Oh, we got a nice little.
Yeah. I think Dr. Brubaker has a question or comment.
Thank you. Yes, I was just going to say, would you use this data equally for someone who had a first-time surgery or a repeat surgery? Or would you counsel differently based on this data?
Well, I think that's a good question. I think that definitely affects the outcome. When we were discussing this earlier, I was saying that this really lines up with what I'm doing already clinically, which I think had been mentioned already, that less severe cases more likely to offer vaginal, let's say in general, whereas more severe cases more likely to offer the sacrocolpopexy. Same with recurrence, I'd probably be more likely to counsel towards a sacrocolpopexy, but I think we just don't have the data here to determine if that was part of the practice pattern for them.
And I'll chime in here. I'm still off mute. Yes. I think that when I was earlier in my career, based on less data and my own personal mentors' experiences, I felt like my tendency was to counsel that that I wanted to make sure their first surgery was their last surgery, that they were not going to have either complications or recurrences. And I think that at that point in time, my tendency was to perhaps push toward what I thought was a durable surgery before we had more data coming out. So I was doing primary repairs as hysterectomies and colpopexies. I know many of my colleagues were, and I'm just curious to know, sort of as the sort of more junior folks and next generation of folks are coming out, as they're watching these data evolve, if they're thinking the same way.
I can let our junior faculty give her opinion on that too.
Yes, I think my counseling is if they don't have as severe prolapse, it's vaginal repair, and then if recurrence, we go for the sacral colpopexy. Obviously, if they're more advanced, then we discuss whether or not they want mesh involved in their repair.
And why do you think that it has to do with the mesh conversation that's happening worldwide?
Yes, and also my patients are pretty well informed regarding issues regarding mesh too. So they're coming in with questions and concerns regarding mesh.
And I'm definitely seeing some discussion here in the chat room that, you know, this is not at all part of this study, but it's definitely an ongoing conversation about the extent to which the genital hiatus, its size if we measure it by POP-Q, or its function if we measure it by functional measures, even just like muscle contractility. But does that have a role to play, and how does that change sort of what we do and what we counsel?
Yeah, I think that's a great question that we don't have enough data to answer right now. I also wonder how many people have a muscular component like a Brink scale or something as part of their assessment. You know, I think we used to be more thorough, and maybe as we get busier, we don't do as thorough an exam, like neuro exam, muscular strength on every patient. Should we not? And how does that weigh in? I think it's a great question.
Yeah, and it would be useful to have that as part of perhaps ongoing data from future studies. Mm-hmm.
Definitely. I think we also got a comment from Blake and Megan, both about GH, and those were some studies that have come out as well, looking at whether GH predicts, you know, recurrence rate or success rate after surgery as well. So there are definitely multiple components that go into the decision, I think, when you're counseling someone. Dr. Brubaker, do you have a comment or question as well?
I was just going to say, I wonder if that's part of the bias, that at some level you feel like the muscular function of that pelvis is healthy, and not even at a conscious level. You say, oh, this muscles are pretty good, and genital hiatus is not that bad. I think we'll get away with the native tissue repair here, and we all know we can counsel a patient pretty much to anything we want them to end up with, and we kind of steer them in that direction a little bit. Whereas we got like nothing moving in the pelvis, hiatus wide open, young woman, very athletically active. We don't put all those things in our database, but in our mental head, we sort of figure this is a problem if we don't get this solved, and we lean toward mesh, I think. But I don't know if everyone runs those same scripts. I just don't know.
I think that's a great point. I think no matter what you give patients the information, they say, well, what would you do? And you have to sort of come back to saying risks and benefits of this choice versus risks and benefits of the other choice.
Well, you're the doctor, right? Yeah.
Right. Exactly. I think Steve had a question or comment as well.
I don't want to sound too unscientific with this, but the patient I saw right before the journal club is like this. You know, sometimes the POP-Q doesn't capture all the factors that you have to treat. And this obese patient who's 50, who's got bothersome prolapse, her urethrovesical junction is sitting basically at the hymen. And that's a problem for a transvaginal approach. I mean, in my experience, it's very difficult to get the anterior wall and the bladder neck up in patients like that. Versus with a sacral colpopexy, what I've done over the last 5 years is I get out of the console, I go examine the patient as I'm suspending the apex and anterior vaginal wall. And I keep checking until I'm satisfied with how much support is there. And I can tell you with that technique, I do a lot less anterior repairs after I'm done with that. You know, and I don't have data to support all that, but, you know, we're all thinking like, yeah, the POP-Q has some gray areas, and this is one of them. So we all have our biases and our algorithms that are kind of softly placed in our mind.
And then just to return back to the question of transvaginal mesh as another option versus the sacral colpopexy mesh support, you know, we still probably need more data for that. And even in the face of the FDA sort of shutting down the actual manufacturers of the two remaining, let's call them kits, that doesn't mean that with appropriate counseling and study, even ongoing studies that we can't still do transvaginal mesh procedures. You can still use the Capio device. You can still cut your own mesh pieces. So I'm just saying that we still need to explore these, because what we're saying, so far Linda, Steve, and I have just been saying is a lot of our sort of biases and practice patterns too. So that's where our journal comes into play. We can continue to assess, work with the scientists around the country and figure out how to continue to answer these questions.
Definitely, and I think that's partly what Blake's saying, is needing a matrix of measurements to put together, into a, kind of a decision analysis of what are the impacts of each of these factors on our success rates. Yeah.
Well, I think this has been a fantastic, and our third journal club has been, from my perspective, fantastic. Thank you, everybody at UNC. I really also appreciate everybody who's sort of chatting online. And I know that it's still kind of an evolving thing, but I really appreciate sort of the ongoing engagement. I can see still people are still, at least their computers are still on. And we definitely would like to continue doing this. We'll check back in with ourselves and with you. So if I see that Linda definitely asked folks to provide feedback, so you can provide it directly to her, to me, or to Steve, whatever you would like, to kind of make sure that we can evolve from this. But for now, our next one is August 29th. It'll be 2 p.m. East Coast, 11 a.m. Pacific, and 8 a.m. Hawaii time. And we will go again.
Excellent. I think, did Steve have a final comment?
Just let your colleagues know that these files, we're still working on this on the journal website and perhaps even OGS, but these files will be available in an archive so that people can listen to them as podcasts. So that way, if people are unavailable, they can still access the content.
And just thanks to the UNC team, you did an awesome job. We really, really appreciate your participation, your contributions on behalf of the journal. It's our professional journal, and we appreciate your contributions. It means a lot to us. Thank you very much.
Thank you. We've enjoyed it. It's been a great opportunity.
Thanks, everybody.
All right. Thank you
very much.
Bye-bye now.
Bye.